Today we're going to talk about deprescribing, also known as tapering, of prescription benzodiazepines. I'm Dr. Alexis Ripp. I'm an assistant professor of psychiatry and the Addiction Psychiatry Fellowship Director at the University of Colorado School of Medicine. I'm also the co-chair and one of the co-founders of the Benzodiazepine Action Work Group at the Colorado Consortium for Prescription Drug Abuse. As mentioned in the previous sessions, I just like to highlight that where my interest in this topic came from was I work in a general outpatient psychiatry clinic, and we have many patients that get sent to us that have been on long-term prescription benzodiazepines, are experiencing adverse effects, and we're trying to figure out the safest and most appropriate way to help them decrease those effects by slowly tapering them. I'm joined by my good friend and colleague, Dr. Gold, and I'll let him introduce himself.
Hello, my name is Dr. Jeff Gold, and I'm a psychiatric clinical pharmacy practitioner at the VA Medical Center in Aurora, Colorado. And I'm also a senior instructor at the University of Colorado Health Sciences Center School of Medicine for the Department of Psychiatry and a clinical instructor for the School of Pharmacy. I became interested in benzodiazepines and working with veterans who were struggling to come off of benzodiazepines. And in doing so, I learned a valuable lesson: that medications are adjusted, started, and stopped in the context of a relationship. And building a relationship with veterans and understanding what was hard for them, what their goals were, has been a big part of working in a benzodiazepine tapering clinic and really setting up patients for success.
Our objectives for today's presentation include utilizing a motivational interviewing informed approach to discuss benzodiazepine tapering with patients, to outline the benzodiazepine withdrawal symptoms, to describe the advantages and disadvantages to different medical approaches to tapering or deprescribing benzodiazepines, to identify adjunctive medications that may be utilized to address protracted withdrawal symptoms while understanding their limited evidence base, and to demonstrate how to utilize the Benzodiazepine Action Work Group deprescribing or tapering guidance. So now I'm going to discuss how to utilize a motivational interviewing informed approach to discuss potential benzodiazepine taper with patients. For those of you not familiar, as well as for those of you that are familiar, I'm going to provide a brief overview of motivational interviewing. There is a large amount of data out there about the effectiveness of motivational interviewing, starting in the addiction field and moving on to just behavioral change in medicine in general. This is a directive, client-centered counseling style for eliciting behavior change by helping clients strengthen their motivation and commitment to change by exploring and resolving their ambivalence about change. Overall, the general principles, which are good for us to exercise in any patient encounter, is to express empathy and use reflective listening to do so, to develop discrepancy between the client's goals and their values and how their current behavior or the current problem might interfere with achieving those goals or values. And you do so by, again, using reflective listening and providing objective feedback. You avoid argumentation by assuming that the client is responsible for the decision to change. So the importance of recognizing and honoring their autonomy. You roll with the resistance rather than confronting it or opposing it. And you support the patient's self-efficacy and their overall optimism to change. This is a chart taken from an article looking at a brief negotiation interview in a medical setting. When thinking about how do you help a patient think about making a behavior change. So first, it's important that you understand their overall concerns and circumstances. And you do this in part by establishing rapport. This may include using open-ended questions to demonstrate your concern for them as a person, like how are they feeling today? Are they comfortable? Asking things like, if I could see the situation through your eyes, what would I see? You want to always ask permission to talk about a subject. Again, thinking about honoring the patient's autonomy. So saying, would you mind spending a few minutes talking about your prescription benzodiazepine and how you see it affecting your current mental health or your anxiety or your insomnia. It's also important to assess a patient's readiness to change and readiness to engage in your treatment or evaluation process. And this may include using a tool to assess their overall readiness and to discuss the results with you. So asking them, how do you feel about tapering or decreasing your benzodiazepine? How ready are you to taper or decrease your benzodiazepine? Often we think about in motivational interviewing using these rulers where you can assess overall readiness to change motivation. For instance, on a scale of 0 to 10, how motivated do you feel to decrease your benzodiazepine? And when they give you a number, you first focus on the positive. So what makes you a 5 and not a 3? And then to help identify areas for continued change or growth, what would help make you a 7 from a 5? And that can be a really concrete way to help patients think about their overall motivation to change. It's also important to raise the patient's awareness about the consequences of the ongoing behavior, or in this case, medication use, and share your concerns. This comes in the form of providing or asking permission to provide feedback to the patient. So saying things like, do I have your permission to provide information about what we know about some of the long-term effects of these medications? They say yes, providing it, or saying, do I have your permission to talk about the results we have from your cognitive screening, which I think might be impacted by your ongoing prescription benzodiazepine. And finally, providing reassurance to the patient that ongoing support in this process is available and will be provided. And that includes open-ended questions about anything else they might want to know about the subject, even if they're not at a point where they're ready to make a change, what they think would have to be in place for them to feel like they're in a place where they could begin to make a change or decrease their benzodiazepine. And if they are ready to change, first eliciting what do they think would work best for them, which approach, questions, concerns they have, as well as asking if you can provide other referrals or support information. Overall, we know that education can be an extremely powerful tool in the setting of recommending benzodiazepine tapering. And this is confirmed by a trial called the Empower trial that was conducted to just see if you provided direct-to-consumer education compared to the kind of usual care approach in individuals over 65 years of age that were on long-term benzodiazepines, what would happen. And so the intervention was, those in the intervention group were mailed an 8-page educational packet about the risk of long-term benzodiazepine use, success stories on tapering, and some of the alternative approaches to treating insomnia, anxiety, and other things that the benzodiazepines were treating versus the control group, which was treatment as usual. And what they found was just providing this information to individuals that were on long-term benzodiazepines led to over a quarter of them discontinuing their benzodiazepine within 6-month follow-up. And that compared with only 5% of the control group. And we have a link here to the educational handout they provided. The one caveat I would bring is that the tapering schedule they provide would be too rapid for many individuals, and we usually recommend starting slower to assess a patient's sensitivity. So indications and benefits to deprescribing or tapering a benzodiazepine. So anyone that's experiencing adverse effects that's impacting their function, there's a loss of efficacy to the benzodiazepine, they've developed tolerance to its effects, they've been on it for more than a month, and certainly if they just request that they would like to taper or decrease or discontinue their dose. Benefits is that actually long-term it can help reduce anxiety, especially if individuals are experiencing interdose withdrawal or rebound anxiety from taking the medication regularly. It can improve overall psychomotor and cognitive function. I would actually say this is probably one of the things, especially the cognitive piece, that is the largest reason I have patients, especially older patients, come in and request that they'd like to decrease their benzodiazepine when they know that this is a risk of the long-term use of the medication. We also know it decreases overall all-cause mortality related to benzodiazepines, and particularly from both overdoses and motor vehicle accidents, as well as falls and drug interactions with benzodiazepines. We know that some individuals that have been on chronic benzodiazepines and develop symptoms that don't have a better explanation can actually find that some of these symptoms actually improve once they're able to taper down or off of the benzodiazepine. But there are risks that come with decreasing these medications that someone's been taking long term. And depending on which symptoms you look at, one study found that anywhere from 15 to 44% of chronic benzodiazepine users experience moderate to severe withdrawal symptoms when they stop the benzodiazepine. There are several factors thought that probably contribute to the increased difficulty of withdrawal. Some of it is this central sensitization that some individuals experience and that we know happens with the GABA receptor, both with alcohol and with benzodiazepines. It's also a phenomenon referred to as kindling, where we know that each time a substance is used regularly and then stopped abruptly or decreased too quickly, the onset of withdrawal will be sooner and more severe. And this is further increased when someone becomes older, has other comorbidities, is on other medications that cause a risk of withdrawal. It's estimated that somewhere around 10 to 15% of individuals will experience a protracted syndrome that could last anywhere from months to years, and possibly indefinitely. Heather Ashton was the provider that really helped identify this, and this is what our previous session our colleagues helped describe, known as benzodiazepine-induced neurologic dysfunction, also referred to as BIND. And this may occur even when a gradual taper is undertaken. We know that tapering off these meds can have severe outcomes for some, including increased suicidality, akathisia, which is also known as kind of an inner sense of restlessness or agitation, and other features of disability. And that there can be a large component of fear and overall ambivalence about no longer being on a benzodiazepine, that even if there are aspects of the benzodiazepine an individual does not like, the fear of what being off of it might feel like and could it be worse than staying on can be quite significant. So it's important that we engage our patients in this mutual decision making about undergoing the process of tapering, and that's collaborative, that we provide consent about this overall risk of decreasing and discontinuing. Ideally, unless it's in the case of severe medical risk, such as an individual experienced severe respiratory compromise from being on a benzodiazepine and other depressing medications, or in the setting of uncontrolled use disorder, we might have to force a taper, but usually in the setting of a benzodiazepine being taken as prescribed, it is not recommended that you force patients to taper. If a patient declines the recommendation or offer to deprescribe, then you should just continue to monitor for adverse effects, and again, assess when and if they'd have some motivation or readiness to attempt to decrease their use. And then some patients will find that they may not be able to discontinue the medication completely, the benzodiazepine, and a more suitable goal may be overall just reduction or maintenance of the current dose. Again, a constant kind of evaluating of the overall risks versus benefits of continuing versus discontinuing the medication. This is actually a good description I recommend everyone read through that Dr. Gold provided of kind of his overall mindset or experience, I should say, of the patient's mindset when really confronting this idea of what discontinuing or tapering and discontinuing their benzodiazepine may be. And I think we as prescribers can initially experience this as a resistance in our patients or them being difficult, but I think we have to realize that while our patients may recognize that there's some component of these medications that is causing side effects or is not helpful, this has been one of their coping skills, whether that's for their anxiety, insomnia, other distress, and their fear of how they will be able to cope without it plays a major role when considering whether they're willing or able to try tapering. And that some of the things they've used these medications for are often some really difficulty experiences and feelings that this medication is helping them avoid or numb. And there's that fear of how they will manage those when they return to experiencing them. And so I think being able to have a discussion with our patients about what it is they've found useful about the benzodiazepines, and sometimes what is useful might actually be something that ultimately is detrimental. Like, is there a way that feeling too numb or avoiding some of these feelings has been difficult or caused problems, and trying to help figure out other ways that we could help them address these issues, develop coping skills, manage their distress, and regulate their affect.
Before we talk more about outlining benzodiazepine withdrawal symptoms, I'd like to discuss the idea a mentor once said to me, Dr. Hartlove, who's a retired psychiatrist from the University of Colorado, that the pill is us. That there's a moment that when a patient takes a medication, they think about the people who provide them that medication, and how they feel about you, consciously or subconsciously, affects how they respond to the medicine. And I think that, as Dr. Ripp pointed out in the previous slide, medications are adjusted, started, stopped in the context of a relationship, and being patient and understanding and interested, curious about what it's like for the patient to take these medications or to be without them, and really engaging them on that level is, I think, a very important part of a successful taper. We're going to define benzodiazepine withdrawal. When a benzodiazepine is used regularly for 2 to 4 weeks or more, it should be tapered to avoid withdrawal. High dose and long-term use in specific are associated with greater chance of developing benzodiazepine withdrawal. During this time, symptoms of pre-existing psychiatric conditions may recur, potentially to a greater severity than during the pre-treatment time period, and they may continue for a prolonged period afterwards. There may be physical and psychological withdrawal symptoms, and when abruptly stopped, the risk of severe withdrawal reactions, including seizures and death, is possible. These medications must be tapered. There are a number of benzodiazepine withdrawal rating scales that you can use in your clinical practice. 2 specific scales have been developed to assess benzodiazepine withdrawal, but have not yet been well validated despite initially being published around 1990. One is the Clinical Institute Withdrawal Assessment, or CWB for benzodiazepines. It's used to assess withdrawal symptoms in patients tapering off or discontinuing benzodiazepines. It's a 22-item questionnaire scoring from 1 to 80 the severity of the withdrawal symptoms. There's also the Benzodiazepine Withdrawal Symptom Questionnaire, which is the BWSQ, and this rates the presence of benzodiazepine withdrawal symptoms as no, yes moderate, or yes severe, as scored as a 0, 1, or 2 point. It's a 20-item questionnaire, and it scores patients from a 0 to 40 to estimate the severity of withdrawal symptoms. This can be very helpful, and I can tell you in my clinical practice I've used these withdrawal scales before as a way to show patients their progress, particularly to give them some comfort and understanding of what they're looking for, what I'm looking for, and it also can help guide the tapering experience. With respect to benzodiazepine withdrawal, it occurs in roughly 50 to 80% of people who have taken benzodiazepines for 6 months or longer. The acute withdrawal phase, from a pharmacologic perspective, may last anywhere from 5 to 28 days. It generally peaks after 14 days, and after this time, most symptoms should return to the extent that they were prior to discontinuation. Benzodiazepine withdrawal symptoms include symptoms common to most anxiety disorders, but it also includes some symptoms that are more specific to benzodiazepine withdrawal. And I also want to say that this is a generalization. Many patients experience severe withdrawal symptoms for a longer period of time after a 14-day time period, and many of the acute withdrawal symptoms can bleed over into long-term symptoms. It is very different by patient experience, but these are, again, generalizations. Some common acute benzodiazepine withdrawal symptoms would be anxiety, panic attacks, insomnia, nightmares are common. Often there are mood changes, depression, dysphoria. Some patients feel restless. There's often a perception that there's a change in their memory. Dizziness and lightheadedness are things that my patients have commonly reported, as well as a tremor. Sometimes there are strange and bizarre muscle sensations, the sense that your muscle is fasciculating, or electrical sensations coursing throughout your bodies, twitches or zaps, I've heard them called. Sweating, particularly at night, is often common, just the sense that you're just constantly sweating, even for people who do not typically sweat. As well as tinnitus, ringing in ears is something that a number of people have described. Distortion of body image. There are some more potentially severe consequences as well in this period of time. And some of those things for some patients could be if a really high dose of a benzodiazepine has been used in a patient for a very, very long time, there's a risk of having a withdrawal seizure. And this can, of course, lead to death. Also, delirium and psychosis have been characterized during this time period, people having altered perceptual states and doing potentially bizarre, dangerous things that are very uncharacteristic of them. I can speak to one particular case of a patient who was abruptly withdrawn from a benzodiazepine with no taper and became psychotic, and it led to a suicide. So there are many risks during this time period, and again, tapering is a must. And this list, though comprehensive, doesn't include even the complete possible spectrum of things that a patient might experience. With respect to the protracted withdrawal phase, it's often difficult for patients and providers to determine the extent of their symptoms prior to the taper. Again, the experience of withdrawal is highly variable from one patient to another, and the protracted withdrawal phase varies significantly in severity and in time course, and it can last weeks to months to years, and the severity can persist to varying extents during that time period as well. Patients can describe benzodiazepine withdrawal symptoms and severe anxiety even while currently using a benzodiazepine too, and as a part of the taper process, and once the taper has been completed. For some patients, these symptoms largely disappear or return to a pre-discontinuation level weeks after the period of peak acute withdrawal, but many symptoms may disappear or decrease in the months and sometimes even years later, particularly as it relates to often memory, cognition, and mood. Some patients report an improvement in anxiety and mood and cognition after discontinuation. They feel that they think more clearly, they have a better sense of regulating anxiety, tolerating distress, making choices informed with a more complete range of feelings, and this can be a very positive thing for people who taper off the medicine. Yet for an estimated 10 to 15% of patients, the symptoms are protracted and may gradually decline but never fully resolve. They may always live with some degree of benzodiazepine withdrawal symptoms. They may episodically appear again sometime later. There are windows and waves, periods of feeling better and then waves of it being worse. And it may linger on for years and may remain severe for some patients and very impairing. This again would be bind benzodiazepine-induced neurologic dysfunction. Common protracted benzodiazepine withdrawal symptoms include anxiety, insomnia, depression, cognitive impairment. There are perceptual symptoms such as tinnitus, paresthesia, that is tingling, numbness, pain. Oftentimes people experience a pain in their muscles or against tension in their muscles. Lots of motor symptoms can accompany this, such as weakness, tension. The tremor can be very painful, jerks in their muscles as well. A number of gastrointestinal symptoms have been described in the protracted and as well in the acute phase as well. And many of these withdrawal symptoms, again, can last for months to even years. And it all, again, depends on the patient. You should be thinking that this is a possibility for somebody even months after the benzodiazepine has been tapered.
I'll just briefly provide another summary of what we are now referring to as benzodiazepine-induced neurological dysfunction, bind, previously under the umbrella of protracted withdrawal, post-acute withdrawal, various names. We have a whole presentation done by our colleagues on this that I recommend you look at. But because it's such an important concept to talk about when talking about deprescribing and tapering and some of the risks to our patients of stopping and starting these meds, some of these symptoms can be experienced while on the meds, when decreasing them, and certainly when discontinuing them. So it's not acute withdrawal, and often we as prescribers are really only trained to look for symptoms of acute withdrawal. That is, while someone is actually taking the medication and it's in the process of being eliminated from the body. Here's the long list of other things that has been called, some particular to benzodiazepines, like benzodiazepine injury syndrome or brain injury, as well as the more kind of general post-acute or protracted withdrawal. So just as a reminder, BIND is a constellation of functionally limiting neurologic symptoms, both physical and psychological, that are a consequence of neuroadaptation and or neurotoxicity to chronic benzodiazepine exposure. These symptoms may begin while taking or tapering benzodiazepines, and they can persist for weeks, months, or even years after discontinuation. Thus far, we know that there's at least 14 categories of symptoms that fall under this BIND constellation, about 7 types of psychological symptoms and 7 physical. I won't review them all here, but you can see, as we said, they can be pretty broad, and it's easy to see how someone could get miss that this is related to their benzodiazepine use, or that these things are being exacerbated by their benzodiazepine use or reduction, discontinuation. And here's the list of physical symptoms. I mean, really fully systemic, both physical and psychologic. I like to draw a parallel that I think it's somewhat similar to what we're seeing with long COVID as a result of COVID, and that probably had we not had long COVID come about so quickly and have so many people affected at once, we wouldn't necessarily believe it. But because it's been in such a short period of time and created such a high degree of disability and dysfunction in individuals, we believe it and are trying to understand it. And I think that's hopefully what we will continue to see more of when it comes to BIND, even though this has been a more insidious kind of long process of identifying it. My hope is someday we'll have more research to really say who is at greater risk of developing BIND, that there's something unique in some people's physiology, in addition to some of the things we know, like when you kindle the withdrawal, it certainly would put someone at greater risk for this. And that a recent survey of individuals experiencing symptoms of BIND found that the most common ones were anxiety, nervousness, fear, sleep difficulties, low energy, and difficulty focusing, among many others. And I highly recommend you look up this recent paper to try to understand this a little more.
We're now going to take a look at the advantages and disadvantages to different medical approaches to deprescribing benzodiazepines, the different tapering methods. Before tapering, remember, the goals for a successful taper are to decrease withdrawal effects and manage rebound symptoms, as well as the recurrence of underlying symptoms that were being managed by the benzodiazepine. It's a lot. Utilize shared decision-making. As described earlier, establish a flexible and gradual taper plan. Dr. Ripp talked about motivational interviewing. I certainly appreciate and employ the shared decision-making model. I often ask the patients, the veterans that I'm working with, what do you feel capable of doing today? Of course, it's my responsibility to make sure that what we do is medically safe and appropriate, but are you ready to do this today? Perhaps something happened in their life and this isn't the right time to make even the most modest of dosage adjustments. Discuss with your patients lifestyle modifications, diet, exercise, sleep hygiene, meditation, and other stress reduction techniques. What else are they doing other than medications or tapering a medication to help take care of themselves? I often ask patients in this time period, which is a difficult time period, what are you doing to take care of yourself? Can you stop throughout the day and ask, what do I need right now to take care of myself? Establish a support system using a multidisciplinary approach. And we've talked about the benzodiazepine peer support document that's available through the coalition. And I think these are really important tools that to make patients aware that they have access to. I certainly find that if during a taper, the patient is struggling with some recurrent themes around maybe some difficulties they've had in relationships or some feelings that have long been numbed or avoided through use of the benzodiazepines, that perhaps it's a good time to return to psychotherapy or to go to psychotherapy for the first time, or maybe psychotherapy at that point feels like too much. But I really engage them, and here are the resources that we have available to you, and here's why you might consider them. Before tapering, you want to stabilize the dose and address interdose withdrawal if present. And ways to do this: you can substitute an equivalent dose. You see our chart before looking at equivalent doses of a longer half-life benzodiazepine, such as diazepam or chlordiazepoxide, and with a stepwise crossover. And this is something that Dr. Ashton, who's of course, one of the most well-known psychiatrists who characterized benzodiazepine withdrawal and the need to taper and what a conservative taper looks like. But switching abruptly is not recommended. There's offer if you decide to taper a patient and working with them on a longer-acting agent, there is a crossover period in which you'd cross-titrate from, let's say, Xanax to diazepam. That's what this is getting at. Or you might use a dose of a short half-life benzodiazepine, but you might use it more frequently, spaced evenly to avoid peaks and troughs in blood levels. There is the potential that people can have interdose withdrawal, which is withdrawing from the benzodiazepine and having withdrawal symptoms between doses. And this, of course, is with a greater concern with short-acting agents such as alprazolam or Xanax. Some general principles to consider. A symptom-based, patient-directed taper is the best approach, as we've talked about. You want to work with the patient. What do they feel capable of? What do they feel comfortable with? Are they ready? You also might initiate a test reduction of the smallest increment possible. If possible, you might shoot for a 5% reduction or even a less than a 5% reduction of the current dose. Consider, and I would advise you to allow the patient to lead subsequent reductions and the amounts, intervals based upon the tolerability and the appearance of withdrawal symptoms. And you do not want to make changes more often than once every 2, even 4 weeks. Lived experience from myself and Dr. Ripp both suggests a 5 to 10% reduction of the total dose monthly is best tolerated. Some people really need slow tapers. Some people are more comfortable with a 10% taper. But again, this is really something that you want to work out with the patient. Be curious about what their experience is like. Skipping doses, supplemental rescue doses, a PRN, or updosing increases the risk of kindling. So you really want to avoid this. You really don't want to go backwards. I think it's advisable if somebody's really struggling with the taper that you keep them at that current dose longer and really think about what else could make them comfortable. But generally, you do not want to updose. Updosing may be necessary in a case of an over-rapid reduction, and if there is, like, let's say, very, very severe symptomatology, such as akathisia or suicidality. In those settings, then, of course, you want to make certain, first and foremost, that the patient is comfortable and can remain safe. Dose reduction should become smaller progressively as the taper progresses. Remember, this is a percentage-based reduction in dose, not an absolute amount that the patient is to be reduced by throughout the taper schedule. So again, think that if you reduce by the same amount throughout the taper, that's a relatively larger percentage later in the taper. 1 milligram in a 10 milligram clonazepam taper, 10% at the beginning, but in the last stage of the taper could be as much as a 50% reduction in dose. Patients will notice that. For many patients, a gradual taper over several months, 3 to 6 months, can be implemented to discontinue therapy. For others, complete discontinuation could take a year or even longer, sometimes even on the scale of several years. The nervous system hypersensitivity is common during withdrawal, and any foreign substance can also have adverse effects. And caution is advised with any new supplement or medication that is added. People can be extra sensitive to other medications that give them a psychological feeling or a physical discomfort, a side effect. During the taper process, use urine drug testing and the prescription drug monitoring program whenever. This should be part of your routine practice. I recommend doing it before, let's say, before the taper begins and then intermittently throughout the taper. And this is, as we discussed in the part 2 of this seminar, that you want to do this for everyone always. Don't leave it up to your projections about who you would get a PDMP for or offer a urine drug screen to. This is something that you should be doing for everybody, and to manage your own biases and to keep everybody safe. It's just part of the practice, and make sure the patients understand that. On this slide, we have 3 different examples of a reduction in the benzodiazepine dose, or what a taper could look like. The first one would be if there was no taper at all. The medication was abruptly stopped. And as you can see, this represents the greatest potential for having withdrawal symptoms and can lead to a number of untoward and very, very dangerous withdrawal reactions. These medications, I cannot say it enough, should always be tapered and tapered slowly. The diagram B represents a taper that might be too fast, or that would likely be too fast. It really shows that in this example, there are 3 reductions and then the discontinuation of the benzodiazepine, and this may not allow the patient enough time to recompensate, to get to a new homeostatic set point where they feel comfortable. This type of taper might result in more withdrawal symptoms. And this also would represent the concern with reducing the taper by a set dosage amount rather than a percentage amount. So for example, going down on a clonazepam, what patients say is taking 10 milligrams of clonazepam a day, and you're going down by 1 milligram at every tapering interval, 2 to 4 weeks. Again, for the first taper, 10%, not unreasonable, but by the time you get to a lower total dosage, a 1 milligram reduction represents a much more significant complete reduction in the total percentage of the medication. So again, you're really looking to use a percentage-based reduction in the medication, which is what C represents, a more slow, methodical taper that minimizes withdrawal symptoms and is based upon the percentage of the dose. Some other tapering techniques you might consider. Before you taper, again, you want to stabilize the dose and address interdose withdrawal if present. You can substitute to a longer-acting agent, as we discussed, diazepam, chloridazine epoxide, or you can use a shorter-acting agent, but you would just use it more frequently. Again, we've discussed this. Many practitioners continue to follow recommendations suggesting conversion from shorter to longer-acting agents in order to decrease the potential for withdrawal symptoms or interdose withdrawal. The data on whether this practice is appropriate or not is lacking, but it may be helpful to some patients. I can tell you in my clinical practice, I give patients the option. I describe to them the advantages of doing a cross titration from a shorter acting agent to a longer acting agent and tapering the longer acting, or why it would be advantageous for them or comfortable to taper a shorter acting agent that's used more often. Some of the advantages of the tapering the longer acting agent, I believe, are to mitigate withdrawal symptoms. And I've had patients tell me who've tapered off of multiple benzodiazepines throughout the taper process that they felt that once converted to a longer acting agent, the tapering process was more smooth, their words often, and that it precipitated fewer withdrawal symptoms, and the withdrawal symptoms were attenuated in their severity. I've had some patients who just said it was much easier and they wish I had convinced them to convert earlier in their care. Some patients that have preferred tapering shorter acting agents have told me that the experience of switching medications in and of itself is traumatic and added a lot of time and difficulty to the process. They've also said that they may just feel more comfortable and safe with the other agent. It's more familiar to them. And it's just been easier for them psychologically to wrap their minds around tapering the agent that they've already been stabilized on. And I really give people the option. Some agents, due to potency, may present other difficulties, and alternatives should be considered. And this would be alprazolam and clonazepam. And part of the reason for this is that, again, due to their affinity for the GABA A receptor, it's thought that these agents have a higher degree of potency and may have even more psychological effects. And for that reason, it may be easier to taper patients off of alternative agents. But again, it may be reasonable to taper these agents. It really comes down to a patient preference. And there are also some considerations around potency of the medication itself, which we will talk about in terms of dosage strength. This is an example of a taper that is too fast for most patients. Some people maybe could tolerate this, but not everybody. But I want to again highlight the point here that this is a patient taking 3 milligrams of clonazepam, 1 milligram in the morning, 1 in the afternoon, and 1 at night. The initial dose reduction of 0.5 milligrams in the afternoon would represent nearly a 17% reduction in their total daily dose. And at the next adjustment, let's say that you were to decrease the morning dose from 1 milligram to 0.5 at the next dosage interval, reduction, that would represent a 20% reduction in total dose. So you can see here that the cumulative, as the dose shrinks, the total percentage goes up, and this can be experienced by a patient as being uncomfortable, that the taper is too fast, and may increase the potential for withdrawal symptoms during the taper process. There are a few taper techniques that you might employ in your practice. One is the cut and hold method. This is a percentage of the current dose is reduced and then held until the symptoms subside in milligrams or a fraction of milligram. The pros of this would be it may be accomplished with existing forms of the drug using a fourth of a tablet or a half of a tablet or a scored 2 milligram diazepam tablet if you convert somebody to diazepam. The cons of this method would be that the symptoms from a larger dose reductions at once may be more intense. Again, you're cutting it by a specific amount each week, and you might not be able to get to the dosage you need to with the available formulations that you have. So an example of the cut and hold method would be a 20 milligram diazepam taper, and you're reducing the dose by 5% every 2 to 4 weeks. That'd be roughly 1 milligram, and held until the withdrawal symptoms subside. The micro taper is another technique that may be considered, and daily micro reductions, and often this is in very, very small amounts, may be utilized, and it could be calculated on a monthly basis. And so this is very, very, very small, subtle reductions that are often or intended to be imperceptible. And again, remember, the goal is to make these tapers as smooth as possible to mitigate withdrawal symptoms as much as possible. So pros of this method, it may allow for a finer adjustment and symptom control, since commercially available benzodiazepine doses can be too large to comfortably taper. That's the disadvantage of the cut and hold method. Many report better symptom tolerability, withdrawal symptom tolerability with this method. The con is that it's off-label and that the method can lead to issues in the accuracy of the dosing. It often may involve some cost. Let's say if a patient has to present to a compounding pharmacy to have the medication made there. These aren't things that are always commercially available. So in this example, 20 milligram diazepam dose, you might cut out 0.07 milligrams daily, representing a 10% reduction in the total dose over a month time period. There are various formulations of benzodiazepines that can be used to facilitate the taper. We've talked about commercial tablet or capsules. You can use the lowest strength of the available medications that you have. You can cut tablets, of course. You can half them. You can quarter them. Quartering them can actually change the dose, and sometimes people are sensitive to the very small doses that come with the tablet crumbling when you attempt to quarter it. Manufacturers also make oral liquids that are available. You can compound these prescriptions at certain compounding pharmacies throughout different organizations. I know Walgreens has a compounding program. Various other pharmacies do as well, independent pharmacies. There are liquid titrations available where you can dissolve essentially the medication in a liquid and use a small amount of that liquid. Now again, I think this needs to be done with the guidance of a practitioner, because not all liquids allow the medication to remain stable. So if you dissolve a bunch of medication in, say, orange juice, you don't know that the acidity from the orange juice is not going to denature the medication or whatever your preferred vehicle of dissolving the medication is. So this really needs to be done with the guidance of a professional or by a professional. And there are other ways of measuring these medications just to get to smaller dosing increments when that's necessary. This table shows you some of the formulations of various benzodiazepines that are available with alprazolam, clonazepam, lorazepam. And what you can see here is the minimum amount of what the minimum dosage available is in a tablet form. And as you can see, that it's hard to get to small doses of a medication like alprazolam or clonazepam. And that can also be another reason for converting people to a longer acting agent. If, let's say, anywhere from 5 to 10 milligrams of diazepam is equivalent to 0.5 milligrams of clonazepam, that it's hard to get to a smaller dosage amount with clonazepam as the agent you're tapering versus diazepam, where you can get to a 2 milligram tablet, which you can split and then quarter that. So these are some considerations. I would also note that the orally disintegrating tablets are also going to be very expensive. So cost is often a consideration when thinking about what agent you would like to use to facilitate the taper. I generally try, if I'm going to convert to a long-acting agent or get to really small dosing increments, I do like converting people to diazepam. But again, many people have a preference otherwise, and there are many ways to do this, and it's part of it is collaborating with the person that you're serving. Now we're going to identify some adjunctive medications that may be utilized to address protracted withdrawal symptoms. And I understand their evidence is limited for doing some of these things, but we're going to talk about why you would use some of these medications and how you would use them and what circumstances. Remember, withdrawal symptoms are best managed by adjustment of the rate of the taper. First and foremost, you want to employ non-pharmacologic measures such as lifestyle modifications, peer support, psychotherapy, and other educational consultations. You want to offer people reassurance, create a sense of control in the patient that is going through this. It's hard. The addition of psychotherapy when tapering benzodiazepines can lead to increased successful tapers and future abstinence rates in patients not already receiving mental health treatment. Such treatments include cognitive behavioral therapy for anxiety and cognitive behavioral therapy for insomnia. There are adjunctive medications that can be used to mitigate withdrawal symptoms, but they are off-label, and the evidence for using these medications is limited, but they may be of some utility. No data suggests that any such medication increases the success rates of benzodiazepine tapers. So use these medications with caution, as many of them have many side effects and concerns of their own. They themselves would need to be tapered as well. And also, many patients experience hypersensitivity during this period to other psychoactive substances, as we've discussed. And a lot of these medications come with side effects of their own that are significant. Some of the medications that have shown to be useful in mitigating withdrawal symptoms include hydroxyzine, carbamazepine, and pregabalin. They all have some benefit for mitigating withdrawal symptoms. The data is quite limited. Among anticonvulsants studied, carbamazepine, valproate and its derivatives, gabapentin, pregabalin, tiagabine, oxcarbazepine, and topiramate. Only carbamazepine and pregabalin demonstrated efficacy in reducing benzodiazepine withdrawal symptoms. The other agents did not, despite there being an overlapping mechanism with many anti-epileptic drugs and benzos, and that they are essentially GABAergic. They enhance GABA neurotransmission. The potential benefit of using an anticonvulsant agent instead of directly tapering the benzodiazepine might be considered if the safety concerns for using the benzodiazepine to complete the taper are too great. So that would be that the patient, in tapering the benzodiazepine, it's too difficult for them and it presents certain safety risks. A good example of this might be somebody who's using, let's say, illicit opioids that they're buying on the street, or they're using benzodiazepines that they're buying on the street, or they're using cocaine or many other substances, that you're concerned that even any amount of benzodiazepine would present a safety risk. And in this case, you might consider a very abrupt taper or a quicker taper. And this also presents a place where you might be able to use some of these medications. These are some of the most difficult situations that you'll come into when you're tapering people off of benzodiazepines, when the risk of them using the medication, even in a context of a taper, may be more dangerous than abrupt taper or using another medication to taper. But one general concept remains that you want to use a medication that's GABAergic to prevent withdrawal symptoms from appearing, because the withdrawal symptoms themselves can be life-threatening potentially, or very severe. So these are very challenging situations, and really it should come down to that you cannot guarantee that the patient can be safe tapering the benzodiazepine and other methods, either abrupt taper or a quicker taper or a more supervised taper, or use of an anticonvulsant medication might be necessary. In a few circumstances, I've seen patients pick up a benzodiazepine script each day in order to preserve the benzodiazepine taper. And I've seen a few folks who've had to be transitioned to other agents, specifically carbamazepine, historically, though this is not routinely done. Some potential pitfalls to watch out for during the tapering process. Published taper protocols are meant to be a guide, and a guide only, and flexibility is key. Remember that the patient should lead this effort unless, again, there are really explicit safety concerns and that need to take precedent. Post-withdrawal recovery may take 12 to 18 months, and for some patients longer. Be aware of that. There's much data on avoiding fluoroquinolone antibiotics. They can precipitate acute benzodiazepine withdrawal. Also, Alcohol and other GABAergic agents can also be of concern. Use caution with progesterone and progestins, which may result in changes to the sensitivity of the GABA-A receptor. There's a lack of clinician consistency in not taking a similar approach for every patient. So many patients have had bad experiences tapering benzodiazepines in the past. My guidance to you is just always listen to your patient. Let them lead the way. Listen to what worked for them and what did not work for them before, if they had tried before. There's actually been research showing that previous attempts at tapering do not predict future attempts at tapering. Remember that physiologic dependence can develop in a matter of days and can occur at prescribed therapeutic doses. I think many people feel sensitive, and rightfully so, that they have been made to feel that there's something wrong with them, or they, as Dr. Ripfo discussed, that it gets labeled as an addiction when in fact it's not. It's a physiologic dependence. Remember that stopping benzodiazepines abruptly, if used for longer than 2 weeks, increases the risk of seizures, psychosis, and potentially death related to these things, and also the development of protracted withdrawal. You want to avoid this. These medications must be tapered. Physiologic dependence is not synonymous with addiction, as we described, and due to the risks of abrupt cessation, addiction treatment centers are not recommended in the absence of addiction. This is not an addiction. Do not discount symptoms that seem bizarre to you. There are such as an example for agoraphobia, or depersonalization, or derealization, or intrusive thoughts, or psychosis, or burning nerve pain, or irritable bowel. These are all real things, and these medications affect your neurotransmitters that float through so many different systems in your body. And I always think that when a patient presents something to me that I've never heard about before, I'm curious about it. I try to read about it. I try to find out what other people have experienced, and I would encourage you all to do the same. Recall that symptoms of benzodiazepine tolerance and withdrawal can mimic other conditions, leading to misdiagnosis and unnecessary testing and medical treatment as well.